I'll be taking October 2021 practice question 4. The question is, a 74-year-old woman with heart failure, bilateral severe osteoarthritis, dyspepsia, presents with severe fall from the bathroom, has been on ibuprofen 400 milligram BD, omeprazole 40 milligram daily, spironolactone 50 milligrams daily, captopril, amiloride, and hydrochlorothiazide. She presents to the hospital due to severe pain. The radiograph is normal. The blood pressure is 115 over 70 millimeters of mercury. The creatinine is 2.3 milligram per dl. The estimated glomerular filtration rate is 20 mL per 1.73 meters square. The packed cell volume is 28%, and the potassium, serum potassium is 5.5 millimole per liter. She was prescribed IV morphine. Okay, sorry, I forgot to update this. 20 milligram 6 hourly, and subsequently discharged home on morphine alongside her regular medications. She represented 2 days later with altered consciousness, vomiting, abdominal distension, and constricted pupils. The questions: 1. What is the diagnosis for the second presentation? List 4 clinical features to support your diagnosis. What are the predisposing factors for the second presentation? What are the principles of management of this patient? And how do you prevent this from reoccurring? Criticize the medications the patient is on. These are the answers. The diagnosis for the second presentation is opioid toxicity. Opioid toxicity from morphine, IV morphine, morphine overdose, and also from opioid toxicity induced by her renal impairment. There are other differentials in this. The first one is a subdural hemorrhage. She's an elderly person, had a fall, and subsequently developed altered consciousness. It's just that in subdural, you don't easily find constricted pupils, except if the person is about to cone, if there's going to be pontine herniation. And in most cases, it's even mydrosis that you have. You can also have another differential of uremic encephalopathy. In this patient that is known to have an EGFR of 20 mils, it's also possible that there's a further deterioration in her renal function and may have also tipped her into end-stage renal disease and subsequently maybe developed uremic encephalopathy. In this elderly patient with these comorbidities and severe pain, there may also be a tendency to self-harm, that is suicide, if she is depressed or has other comorbid psychiatric condition. The 4 clinical features to support the diagnosis, these include altered consciousness, constricted pupils, vomiting, and abdominal distension. The opioid overdose trial include respiratory depression, reduced level of consciousness, and the pupillary constriction. The vomiting and abdominal distension may be explained by dysmotility that can be gastrointestinal dysmotility that can be found in opioid overdose, because there can be gastric peristalsis, and then in severe cases you can have a paralytic ileus. The predisposing factors for the second presentation. In this index patient, her renal impairments. She has reduced renal function, and the pharmacokinetics of morphine or opiates in general, the renal failure may result in accumulation of the parent compound or the active metabolite. Morphine in this case is broken down by the liver and undergoes glucuronization to morphine 3 glucuronide and morphine 6 glucuronide, both of which are excreted renally. And morphine 6 glucuronide is more potent than morphine itself. Worse still, when a patient has end-stage renal disease, the half-life is increased to about 50 hours, compared to 3 to 5 hours in patients who have normal renal function. And because of this impaired renal function, these metabolites can accumulate and also lead to opioid toxicity. The high dose of morphine, this is an elderly patient. She was prescribed 20 milligrams of oral morphine 6 hours in patients, and especially elderly people who are more susceptible to adverse effects of adverse effects of opiates and even other analgesics. It would have been better to give the lowest effective dose to achieve to achieve analgesia in this patient. Older age, like I said, and also polypharmacy. She was already on a lot of other medications, and there's increased risk of drug-drug interactions. The principles of management of this patient. Opioid toxicity is a medical emergency and thus requires immediate resuscitation. The ABC of resuscitation should be, the protocol should be employed. First priority is to secure the airway, support breathing, supplemental oxygen, can use endotracheal intubation too. A brief history and physical examination, maybe from the bystander or the family or friends, whoever that brought the patient, to also rule out other possibilities and to confirm that you're dealing with opioid toxicity. Administration of antidotes, in this case, naloxone, which is a competitive antagonist of the opioid receptors, is given preferably IV. However, it can be administered intranasally via the endotracheal tube, IM, and subcutaneously. Reassessment of the patient after each dose of naloxone to ensure that opioid reversal, or to check if opioid reversal has occurred. Renal replacement therapy. In this patient, she already has a renal impairment, and if it has deteriorated, may need to undergo a form of renal replacement therapy. In this case, it might be peritoneal or hemodialysis. But it is worthy to note that morphine is not cleared by most opiates are not cleared by hemodialysis, especially the fat soluble ones that has high lipid solubility, like fentanyl. Review of medications and use of alternate analgesic agents. These patients' medications need to be adjusted. The morphine dose, it might be better to stop the morphine and look for alternative means of analgesia, or co-prescription of morphine with buprenorphine and naloxone. It might also be better to look at other forms of analgesia. It's true she's already on ibuprofen 400 milligram BD. She can have other forms of other analgesic agents like paracetamol added to it. Patient monitoring. She needs to be monitored. She should be admitted, even after the opioid reversal, she should be admitted for at least 12 to 24 hours to ensure that respiratory depression or altered consciousness doesn't reoccur, because it's been noted that in some patients, even after opioid reversal, owing to the long half-life of the medication, can also experience another respiratory depression, altered consciousness again. So you need to monitor for some time, and if all remains well and patient is stable, can now be discharged probably within 12 to 24 hours. Patient education and counseling. She should be counseled on the medication she's on, and then she should be counseled on the medications and the comorbidities and how to manage most of them together. How do you prevent this from reoccurring? Patient education and counseling, like I said, use of the lowest effective dose of medication with appropriate dosing interval while taking into consideration the presence of comorbidities. In this case, we have renal impairment. And liver diseases is also noted because the opioids are broken down by the liver. In a case of liver disease, patient may be predisposed to more opioid toxicity. Analgesia with alternative agents, example, buprenorphine or co-prescription of naloxone, like I said before. Monitoring opioid prescription and dispensing via the Prescription Drug Monitoring Program. This is a monitoring program aimed at making sure that there is appropriate to prevent irrational and inappropriate opioid prescription and opioid diversion. This program was instituted in the US and some other Western countries to try to reduce the opioid overdose cases they were having, because it was already becoming an epidemic around 2010 to 2016. The WHO and the United Nations Organization on Drug and Crime in 2016 tried to bring out some ways of preventing opioid overdose, but they noted that there's a lot of gap between the recommendations and the implementation of their recommendations. They proposed increasing the availability of opioid dependence treatments, including those on prescription and also those that are opioid dependent, reducing and preventing irrational or inappropriate opioid prescribing, monitoring opioid prescribing. Initially, physicians who are authorized to prescribe opioids, they had a particular number. For you to prescribe an opioid, you need to go through certain channels to make sure that it is prescribed to the right person and there is a reduced risk of opioid use dependence in the patient, and also search the database to know if there are people who are already known to have opioid use disorder, and that will determine how you go about the prescription and the subsequent monitoring. Also, they recommended limiting inappropriate over-the-counter sale of opioid is a controlled medication and shouldn't be sold over the counter. Criticism of the medication patients is on. Morphine. Patient had high dose morphine in an elderly patient. Using the oral solutions, it's true that patients can get up to 10 to 20 milligrams 4-hourly, depending on the severity of pain. But in an elderly people who are susceptible to increase the adverse effects of opioid medication, it would have been better to give them lower doses and at increase the dosing intervals instead of the 6-hourly. Ibuprofen 400 milligram BD. It could be the cause of the dyspepsia. It can also worsen an already existing dyspepsia. It also worsens renal function, that's NSAIDs, and then it increases fluid and water retention, which can worsen the heart failure in this patient. Omeprazole 40 milligrams daily may increase the risk of osteoporosis in this patient, and subsequently their increased susceptibility to falls and fractures in these elderly people. Spironolactone 50 milligram daily. This is a high dose potassium sparing diuretic. Patient's serum potassium is already 5.5 millimole per liter. That is the upper limit of normal, and it could worsen the hyperkalemia. Captopril is also an angiotensin converting enzyme inhibitor. It's also known to be potassium sparing. Amiloride is also potassium sparing, and all this can worsen hyperkalemia. Hydrochlorothiazide, also a diuretic, and together with the high dose spironolactone and amiloride can lead to orthostatic hypotension in this elderly patient and increase the risk of falls and fracture. Could also be a predisposing factor to the first presentation that the patient had. Okay, a brief overview of the opioid overdose as toxicity. I'll go with this outline. This has been presented before, so I'll just mention a few things. So I've already spent 15 minutes. Opiates are naturally occurring substances derived from the opium poppy plant. While opioids are natural, it could be semi-synthetic or synthetic agents that act on the opioid receptors. The natural opioids commonly available are the morphine and codeine, the semi-synthetic opioids, hydrocodone, heroin, and the synthetic ones like fentanyl and pethidine. The epidemiology, according to WHO, worldwide in 2019, about 600,000 deaths were attributed to drug use, and close to 80% of these deaths were related to opioids, with about 25% of those deaths caused by opioid overdose.
Dr. Pete, you can just leave the epidemiologist to go to pathogenesis or pathophysiology.
The pathophysiology, the opioids are substances that act on the opioid receptors, the mu, kappa, and delta receptors. These receptors are located in the brain, spinal cord, and the gastrointestinal system. The opioids, they act via the endogenous opioid system by acting as a potent agonist on the receptors. This results in a complex cascade of intercellular signals, resulting in dopamine release, the blockade of pain signals, and sensation of euphoria. The opioid receptors and different organs of the body mediate several functions. The mu receptors are commonly the ones that mediate sedation, euphoria, and analgesia. Also, this motility in the gut. The kappa receptors, most of that. The delta too does also mediate euphoria. The sigma receptors are the ones that over time were removed as opioids because they were found to have a psychiatric manifestations like nightmares, hallucination, and those are the most of the functions that they mediate. Opioids can be taken orally, it can be taken intravenously, intramuscularly, subcutaneously, intranasal, use of endotracheal tube. They are broken down by the hepatic cytochrome enzyme system into its metabolites that are excreted primarily by the kidneys. The codeine are metabolized by the cytochrome P450, CD2, CYP-D2, and converted to morphine. Then morphine will now undergo glucuronization, like I said, and then the metabolites are excreted by the kidneys. So when the kidneys are impaired, the metabolites can accumulate and lead to this opioid toxicity. The causes of opioid overdose, they include opioid use disorder, therapeutic error, unintentional overdose like in suicide, unintentional overdose like in children or those taking care of people on opioids and they mistakenly ingest opioid medications in large doses, or even those who are on prescription opioids but maybe have other comorbid psychiatric or medical conditions and subsequently take higher doses of opioid. Intentional overdose that, like I mentioned, maybe suicide. The risk factors are here. The clinical features, the opioid overdose trial, respiratory depression, central nervous system depression, and pupillary meiosis. But it's also worthy of note that constricted pupils or midpoints or pinpoint pupils are not universally seen in patients that have opioid overdose. In some cases, you might even have mydrosis. The respiratory system, you have a slow and shallow breathing, 4 to 6 cycles per minute. For the skin, you can have needle track marks, patch marks, flushing. Some opioids lead to histamine release and lead to urticaria, itching, and flushed skin. Cardiovascular system can have severe hypotension, bradycardia, and arrhythmias. Also, co-ingestion of opioids together with other sedatives and maybe some tricyclic antidepressants predisposes to QT prolongation and subsequent development of arrhythmias. Example is torsades de pointes. In the gastrointestinal system, you have nausea, vomiting, constipation, and in severe cases, you have paralytic ileus. This can also explain the abdominal distension that the patient had. urinary urogenital system can have urinary retention from urethral sphincter spasm and decrease detrusor muscle tone. The investigations, opioid toxicity is usually a clinical diagnosis, but you can do urine drug testing, which is quite sensitive and can pick up opioids in urine up to 48 hours after taking injection of the opioid. Arterial blood gas determination in a patient who is unconscious with respiratory depression, you may want to be sure that you're dealing with just opioid toxicity and not other causes of respiratory failure. Electrolytes, urea, and creatinine will help to rule out renal impairments and other electrolyte abnormalities. ECG, like I said, you can have QT prolongation and arrhythmias, like to the point. Chest X-ray, in cases of acute lung injury, which is commonly seen in heroin overdose. Abdominal X-rays in people who are body packers trying to transport opioids from one location to the other. Abdominal X-ray will show those facts. Differential diagnoses include benzodiazepine barbiturate toxicity. These cause CNS depression, clonidine toxicity, even hypoglycemia, meningoencephalopathy, like in patient that has meningoencephalopathy can have CNS depression, alcohol toxicity too. The management is an emergency care, ABC resuscitation, oxygen therapy, administration of naloxone is usually given in adults IV 0.4 to 1 milligram per per dose, and then can be repeated in 2 to 3 minutes until opioid reversal occurs. But while at that, you also look for patient might start to experience withdrawal symptoms like agitation, increasing pain from maybe the condition that we're trying to manage with the opioids, and then you need to use alternative pain management options. In this case, you can use buprenorphine and also co-prescription with naloxone too. And for patients who have opiate use disorder or narcotic overdose, this combination reduces the withdrawal symptoms for about 24 to 30 hours. Continuous cardiorespiratory monitoring, like I said, to observe the patient for 12 to 24 hours to make sure that the patient is not at increased risk or also going back into the opioid toxicity or manifesting the same clinical signs again. Patient education and counseling. Correction of fluid and electrolyte derangement when necessary. GIT decontamination. This can also be done using activated charcoal in cases where the patient is still conscious and took large doses of opiates. You can do gastric lavage, whole ball irrigation. This can be used in body packers who have a large doses of the opioids, maybe busted in the GI tracts, and then you can do whole ball irrigation for them. The complications, the major cause of, I think this is the last few slides.
Okay, all right. Thank you, Faith, for a wonderful presentation. We've had this presentation before now, but if you have any clarification, any contributions you can make, Dr. Faith, can you unshare your slides so that the next presenter can, while we get contributions from the class. Okay, Dr. Momodo has an add-on note for naloxone. Okay, so saying that naloxone has a half-life of 30 to 80 minutes. So while managing opioid toxicity, if the patient has an incomplete response to initial management, or patient has ingested a large quantity of long-acting or sustained-release opiates, they are likely to need further doses when the initial IV or IM naloxone wears off, as evidenced by initial wears off as evidenced by initially better, now worse, better. So this could be managed with repeated doses of nebulized naloxone or repeated IV. However, the titration of this can be difficult and deterioration could be unrecognized. So IV infusion of naloxone should be considered. So 2 milligrams of naloxone in 500 mils of normal saline running at 100 mils per hour. That's at 400 microgram per hour. Okay, so Dr. Chikase, thank you for your presentation. Opioids and opiates, are they exactly the same? Opioids and opiates, are they exactly the same? Then for Dr. Mohammed, the activated charcoal ineffective for metal toxicity. Okay. All right. So Dr. Faith, Dr. Ibe is asking, opioids and opiates, are they the same? Is Dr. Mustafa in class? Should be sharing your slide by now.
Okay, sir.
Okay. Okay, thank you for the question. Thank you for allowing me present. Opiates and opioids, opiates are natural occurring substances that are seen in the natural occurring substances gotten from the poppy plant, and they act on the opioid receptors. They are natural occurring, that's for opiates, while opioids are, it could be natural, it could be synthetic or semi-synthetic, that also acts on the opioid receptors or opiate receptors. Do you understand? Opiates are only naturally occurring substances, but opioids are other substances that act on the opiate receptors.
Okay, all right, thank you very much. So they can be interchangeable. They can be used interchangeably, but as she explained, opioids are naturally occurring, and then opioids are both naturally occurring, semi-synthetic or synthetic. Dr. Tanimo, can you go ahead?
Thank you very much for this presentation. Is it not the robust definition that the opiate, OPIODs, are the natural ones, while the OPIATE are the synthetic ones? I think it is the robust of the definition you are giving.
The way she explained it is correct.
Okay.
Yes, opiates are natural opioids, while opioids are both natural, semi-synthetic, or synthetic.
Okay, thank you very much.
Very welcome. All right, thank you. Okay, Dr. Ekele is saying, thanks. Yes,
Dr.
sir.
So that everybody gets it and it's clear. Opioids are anything that act on the opioid receptors, okay? So whether it was naturally, it occurred naturally in the environment, or it was developed in a lab synthetically, right? So everything that acts on the opioid receptor is an opioid, right? Now, opiates, on the other hand, are substances that act on the opioid receptors that are gotten from your normal flora, okay? Normal plants and everything, right? So your poppy plant and all of that. So opiates are a type of opioid. I think that makes it clearer.
Yes, sir.
Yes, all right.
Thank you, sir. Dr. Ekele is saying, okay, thank you for your presentation. Is there any danger in giving NSAID and ACIs together, like this patient was on? I think she explained that, but Dr. you can go ahead.
Okay, thank you for the question. I think when you co-prescribe NSAIDs and ACE inhibitor, it reduces the effect of the effect of ACE inhibitors is decreased, and then maybe it might worsen the heart failure symptoms. It might worsen the heart failure. But I can't remember the exact mechanism by which it does that.
The
Maybe
combination of
someone can help
NSAIDs,
me.
PCIs on the
And
heart
AC
or on the
inhibitor.
kidney.
I know that it reduces the BP lowering effect of AC inhibitor, but
Is
it's
that
not
what
clear
it
now.
does? I think you don't tend to give them together. We're coming from the point of view of a nephrologist. You don't give NSAIDs and ACIs together because one, you have a higher chance of hyperkalemia, and then two, it reduces the GFR. Okay, we know that when you give somebody an NSAID, because of its inhibition of the production of prostaglandins, it prevents the vasodilatory effect of prostaglandins on the afferent arterioles. So the afferent arterioles will then constrict, and that will drop GFR because it will reduce the glomerular perfusion pressure. Okay. And on the other hand, if you give somebody an ACI, what ACIs do is that they prevent the production of angiotensin 2, which is a potent vasoconstrictor and causes the constriction of the efferent arterioles. And when you cannot constrict the efferent arterioles, they dilate, hence also dropping the glomerular filtration pressure, and hence reducing glomerular filtration rates. So when you combine the two of them together, you now have an overwhelming reduction in the glomerular filtration pressure, and that will eventually lead to a significant drop in the GFR. And yes, other things they will do will include hyperkalemia as well. So I think that's from the point of view of the kidneys, but on the heart, I'm not so sure what it does. Okay, but I'm sure we can plot it out from the mode of action of both medications. But I'm sure of this action on the kidneys.
Okay, thank you so much.
Thank you very much. Is there any other contributions? Dr. Mustafa, you can put it on slideshow so that.
Hello, good morning.
Yeah, good morning.
Yes.
All right, so in the absence of any other contributions, so we can go ahead.
Okay, thank you very much. Good morning, consultants, senior colleagues, and colleagues here present. Today, I will be looking at the West African October 2021 practice question 3.
Dr. Mustafa.
Sorry, can you hear me, sir?
Yeah, we can hear
you.
Can
I be heard?
We can hear you now.
Okay, sorry. The question reads, Mrs. X. Sorry, maybe let's start all over again. Good morning, my consultants, senior colleagues, and colleagues. So I'll be taking the question 3 of the West African 2021 recall practice question. So the question reads, Mrs. X presented with 3-day history of diarrhea, vomiting, abdominal pain, jaundice, and smoky urine, and then history of fever, with a temperature of 38 degrees Celsius and a pulse rate of 120 beats per minute, with a blood pressure of 100/50 millimeter mercury. EU creatinine showed urea of 30 millimoles per liter, with a creatinine of 304 micromole per liter. Then urea creatinine ratio of less than 10:1. And a hemoglobin of 8.9 grams per deciliter with a platelet count of 105,000. Then there's also another hemoglobin value of 8.3, with a urine microscopy showing granular Moody cast. So the question reads, what is the diagnosis? And explain the differentials in this patient. Then the B part says, what other investigations will you do? And then C, how will you treat? So looking at this question, actually, if you look at it clearly, there are 2 values of hemoglobin that were given. So I don't know, maybe is it a recall failure, or it may be right actually if the other hemoglobin is of the serum-free hemoglobin. These serum-free hemoglobins, they are actually used as markers of hemolysis. So if the patient has hemolysis, there will be rise in the levels of the hemoglobin as against the normal hemoglobin individual, where in anemia you have a decrease in the level of the hemoglobin. So the normal values of the serum-free hemoglobin is less than 5 gram per deciliter. So whenever you have serum-free hemoglobin greater than 5, it signifies an ongoing hemolysis. So I don't know, maybe if it's a recall failure. So maybe we may entertain contributions and then additions from those that have attempted this question previously. So the diagnosis. So based on the history that was given, the first diagnosis I entertain in this patient is hemolytic uremic syndrome. That's HUS, probably the diarrhea associated. Because of the history of diarrhea the patient presented with, the abdominal pain, the fever, and then the jaundice. And then the history of anemia, the low hemoglobin count, and then the deranged renal function, and then low platelet count. However, in the investigations, apart from that other hemoglobin that we were saying, maybe probably a free serum hemoglobin that may actually indicate hemolysis, we were not given other things in the investigation to show whether this patient is actually hemolyzing or not. But practically, you can look at it. The patient is having jaundice, and then the patient is having passing a dark-colored urine, which may actually suggest an ongoing hemolysis in this patient. For us to diagnose hemolytic uremic syndrome, there are the clinical triad of macroangiopathic hemolytic anemia, that's MAHA, thrombocytopenia, and acute kidney injury. If you look at this patient, the patient has thrombocytopenia, the platelet count is low, and it has deranged renal function. The microangiopathic hemolytic anemia, that's why I'm saying maybe the question has actually recall failure, or that free serum hemoglobin may be only the indicator for hemolysis that was given in the question. So the other differentials that are entertained in this one would be sepsis. Obviously, because of the symptoms the patient presented with, the patient has features of infection, the fever, tachycardia, and the blood pressure is going towards the lower side with the AKI and then the hemolysis. With that system involvement, patient is having, of course, in sepsis, you can have anemia from hemolysis as well. So, and then the other thing is the urea creatinine ratio that was given is actually suggestive of an intrinsic or an acute tubular necrosis, which is less than 10:1. But in sepsis, you usually expect a form of a pre-renal AKI, where the urea creatinine ratio may be greater than 20:1. But nevertheless, even in sepsis, if the inflicting or the initiating of a mechanism is not well treated, they can progress to have a intrinsic or acute tubular necrosis. So the second differential I entertain in this patient is AKI secondary to gastroenteritis. Of course, the patient has vomiting, diarrhea, so volume contraction. It can also have prerenal AKI. As I said earlier, the urea creatinine ratio expect in prerenal AKI to be greater than 20:1. Then the third differential I entertain, of course, you can't talk about hemolytic uremic syndrome without talking about the other TMS. That's thrombotic thrombocytopenic purpura. But that one actually acts pentad. Apart from the 3 features you see in HUS, in patient with TTP, they have additional history of fever and then neurological features as well. Though in these patients, there are no features suggestive of neurological involvement, though it's actually differential, so we may entertain possibility of this as well. So the other differential diagnosis I entertain in this patient is a full blood count, though we are given anemia and then the low platelet count. This patient may also show presence of the leukocytosis. So peripheral blood film, which is very important, which may show presence of hemolysis. You may see presence of schistocytes and then helmet cells. Then urinalysis, in addition to the granular cast that was given in the question, you may as well see red blood cell counts, hematuria, even proteinuria. And then other markers of hemolysis, especially elevated lactate dehydrogenase, may be present if the patient has fully hemolytic uremic syndrome. And then liver function tests, they may have elevated bilirubin. And then you may request for a stool culture because this patient is having diarrhea and then fever to look at it. So because hemolytic uremic syndrome, especially the diarrhea associated, is usually due to E. coli or Shigella infection. And then you can also request for a blood culture because the patient is septic, which may also help in the evaluation and management of this patient. So other investigations that you may request for are ELISA test to detect for the sugar toxin, because HUS, the diarrhea associated, is sometimes actually called the sugar toxin associated, because it has been found that the E. coli strain 0157H7 produces this sugar-like toxin, which actually causes this pathophysiologic mechanism, thereby leading to all these abnormalities in this patient. So detection of the sugar toxin may point towards hemolytic uremic syndrome, which may be sugar toxin associated. And then screening of Adams TS13 activity, which are actually reduced in patients that have TTP to differentiate HUS from TTP. And then you can also test for factors like factor H antibody and then complement, which may be associated with poor outcome in this patient. Then the ultrasound scan may also be done to rule out obstruction, because the patient is presenting with a deranged renal function, though they didn't say whether the patient has a decline urine output or not in this question. So the next question says, how will you treat? So management usually is multidisciplinary, involving the nephrologist, the intensivist, the clinical hematologist, and then the gastroenterologist. So patients should be ideally admitted HDU and then or ICU facility. And then basically the treatment is said to be supportive. Then patients are usually dehydrated. So dehydration with fluid, preferably normal saline. Then red blood cell transfusion, because these patients are hemolyzing, they are anemic, then as indicated. Then they may also require plasma infusion and then plasma exchange. And then hemodialysis if indicated, that's if the AKI progress or the patient has some clinical features of uremia, they can also benefit from hemodialysis. Then avoidance of nephrotoxic agents as well. So I would just like to give an overview on hemolytic uremic syndrome. So hemolytic uremic syndrome is a heterogeneous group of diseases that result in a common pathology, that's the thrombotic microangiopathy, that's the TMA, which involves the HUS and then the TTP. It is characterized by progressive renal failure that is associated with microangiopathic hemolytic anemia and thrombocytopenia. If you look at a patient, the patient actually had AKI and thrombocytopenia, though we could not substantiate actually whether the patient has a hemolysis or not. And then it is the most common cause of AKI in children, and this disease is now recognized in the adults as well. HUS is most commonly caused by sugar toxin. That's the typical HUS, or less commonly, some can also result from some infections, genetic abnormalities, or which the other type, that's the atypical, which result from activation of the alternate complement pathway. The additional causes of secondary HUS may include malignancies, autoimmune diseases like SLE, genetic mutations, and even pregnancy, and some medications used can not be associated with hemolytic uremic syndrome, like the mitomycin C or the other cytotoxic medications that are used. Then extrarenal manifestation in HUS are common, particularly neurological symptoms. But if you look at it, I said earlier, what differentiates TTP from HUS is the presence of fever and then neurological symptoms. TTP, the neurological active symptoms actually predominate, while in HUS is the AKI or the renal manifestation that actually predominates. That doesn't mean that patient with HUS, you may not see neurological symptoms. You can as well present with some neurological signs and symptoms. So identifying the underlying trigger for TMA can be challenging, especially that's whether it's toxin, the sugar toxin associated or not. But it is imperative in personalizing disease-specific treatment in these individuals. So to classify the patient as either having typical or atypical may have some significance in treatment. The prior classification of HUS often depends on the presence or absence of bloody diarrhea, which is presence used to diagnose typical HUS, that's diarrhea-associated HUS or the sugar toxin associated HUS. But those patients that present with typical triad without diarrhea are classified as non-diarrhea associated or non-sugar toxin associated. However, the atypical HUS can also present with bloody diarrhea in about 30% of these individuals. So presence or absence of diarrhea may actually not necessarily differentiate typical from atypical HUS. So in Asia and Africa, typical HUS is often associated with sugar toxin producing Shigella, while in North America and Western Europe, 70% of sugar toxin associated HUS cases are secondary to E. coli serotype 0157H7. So there are other E. coli serotypes implicated in causing hemolytic uremic syndrome apart from the commonly known 0155H7. This includes the 0111H8, 0103H2, and the rest of them. So the non-sugar toxin may occur at all age, unlike the typical that we say is common now in children, but the atypical can occur at all ages, and also more frequent in adults. May occur with or without predominant diarrhea, as I said earlier. It can also occur in sporadic cases or familial. So in the familial, may be associated with some genetic abnormalities of the complement regulatory proteins. So other causes of atypical HUS, as I said, can be from infections like strep pneumonia, which accounts for 5 to 15% of patients. So in these patients that have HUS because of strep pneumonia, they present with pneumonia or even meningitis as well. So viruses are also implicated in causation of HUS. That is the atypical HUS like HIV or the influenza virus. Then autoimmune diseases, drugs, then even malignant hypertension. And then recent studies have shown that COVID-19 can also trigger atypical HUS in both children and adults as well. So the pathophysiology mechanism. So thrombotic microangiopathy encompasses various systemic diseases in which endothelial damage causes thrombosis in the microvasculature, including the capillaries, arterioles, and then the venules, resulting in consumptive platelet aggregation. This leads to mechanical shear of the blood vessels of the red cells, then causing degradation or breakdown of hemolysis. And then they are usually negative hemolytic anemia. And then patient may present with end organ damage, particularly the kidneys, the nervous system, but other organs can also be affected as well. This is a particular mechanism. I'll go to share the slides. So let me just go quickly to the clinical features. So sugar toxin producing E. coli is the most common cause of HUS, as I said, accounting for 90 to 95% cases, commonly arises from consuming contaminated food or drinks, and even through person-to-person contact. The incidence of HUS among individuals infected with STEC ranges from 5 to 15%, and predominantly affecting children under the age of 5. Typically presenting with bloody diarrhea occurring 2 or 3 days following the exposure, with the HUS onset developing 3 to 10 days after the short episode of diarrhea. So other common symptoms are vomiting, which occurs in about 67% of patients, of which this patient has, and then fever in about 37% of patients, or the patient also has, and then abdominal pain of 29%. So this patient has most of these symptoms that the patient tends to present with hemolytic uremic syndrome. While atypical constitutes lesser percentage, accounting for 5 to 10% of HUS cases, and is linked to genetic mutation affecting the alternate pathway. The initial clinical presentation of atypical HUS is usually non-specific symptoms such as fatigue, pallor, or somnolence, which can progress to signs of end organ damage. So if the inciting factor is strep pneumonia, that's causing atypical, as I said, they may have underlying pneumonia, emphysema, or even meningitis. So how do you evaluate these patients? The diagnosis requires high index of suspicion based on symptoms, travel history, laboratory data, and then dietary history. The initial test should include a complete blood count with differentials, in which we say we can see leukocytosis, you can see anemia, and then thrombocytosis, and the patient have elevated lactate dehydrogenase. I've mentioned these ones during the course of this presentation. Then the treatment, how will you treat this patient? That was the last question. So as I said, largely is supportive fluid management based on intravascular status. Then hematological manifestation usually resolves spontaneously in about 2 weeks, followed by the renal recovery. So that's the hematological manifestation actually recovers first, then followed by the renal. Then blood transfusion may be required as necessary, then avoid nephrotoxic. And up to half of patients may require hemodialysis. So anti-motility agents and then antibiotics should be avoided in patients with typical HUS, as this correlates with poorer outcome. The use of antibiotics in patients that have atypical HUS, it has been found that especially the antibiotics that actually act on the cell wall, causing lysis of the cell wall, thereby releasing more toxin into the system and then causing more damage in the system. That's why antibiotics are actually should be avoided in patients with the typical HUS, or at times antibiotics have been found to actually predispose patient to development of HUS, the HUS in patients that have infection by this strain of E. coli. On the other hand, if dysentery or pneumonia is present, early antibiotics may be required. So depending on what you are dealing with, if you are suspecting a Shigella or a strep pneumonia as the cause of the atypical, so antibiotic in this instance may be required. For atypical HUS, early treatment is crucial to avoid any organ damage because it is associated with poorer outcome, as I said. The cornerstone of treatment of patients with atypical HUS are the first line treatment with eculizumab and a second line plasma exchange. So patients with atypical HUS may actually present with these monoclonal antibodies. With the advent of eculizumab, treatment has decreased progress. With the advent of eculizumab, so treatment with these drugs has decreased the progression to end-stage renal disease and death. So it has been found that the use of this drug has been found to be beneficial, and then it reduces the poor outcomes seen in this group of individuals. Another drug, that is the ravulizumab, is also a new C5 inhibitor approved for use in the United States in 2019 and in the European and in the 2020. It also binds to C5, thereby preventing cleavage, and it has similar efficacy to eculizumab, but with 4 times as long as half-life as the eculizumab. So this drug seems to be better than eculizumab in terms of the half-life. So differential diagnosis, I mentioned earlier, TTP, disseminated intravascular coagulation, HEP syndrome, systemic vasculitis, sepsis. These are all differential diagnoses of HUS. So the prognosis, AKI occurs in 55 to 70% of patients with typical HUS, but tend to have a favorable outcome. They have a better prognosis compared to those that have atypical. So patients with the atypical have poorer outcome, with about 50% progressing to end-stage renal disease or irreversible brain damage, and up to 25% of patients die during the acute phase. So hemolytic uremic syndrome is a rare but potentially serious condition, often due to infection or less commonly due to some genetic predisposition and other underlying conditions. So prompt recognition of the various etiologic mechanisms and manifestation is essential for timely diagnosis and intervention and management to improve patients' outcome. So
thank you, Dr. Mustafa, for a wonderful presentation. It's time for contribution questions, clarifications. You can type in the chat box or you can raise your hand to make your contribution. And okay, I think Dr. Mustafa, you have dropped the presentation on the chat.
Yes.
Okay. And Dr. Faith too, you can also drop your presentation and other people that have not dropped their own slide presentation on the WhatsApp group, please, you can do that as soon as possible. All right, Dr. Yusuf, you want to say something?
Thank you very much, my chief, for the presentation, Dr. Mustafa Lawan. Please, my question is, I want to ask regarding the use of antibiotics.
Yeah.
You said S. dysentery or if S. dysentery or Streptococcus pneumonia is the implicated organism, the use of antibiotics is actually, it improves outcome.
Yes.
So can we say generally that for atypical, since you said that most of the atypical HUS, S. pneumonia is just one of the implicated organisms. So can we say generally that the use of antibiotics is preferred for atypical, unlike the typical HUS? Thank you. That's my question.
Thank you, Dr. Yusuf Rahim, for that question. And I think that is why they are now shying away from that classification that uses diarrhea associated and then the non-diarrhea associated, because it has been found that even the patient that have diarrhea may have atypical HUS. So, and one paramount thing is that recognition of the etiological factor is very important in management of this patient. Because if you look at the antibiotics that you may use in patients that have strep pneumonia, they are those ones that are the ones that do not affect the cell membrane. So what I said, in the E. coli producing Shiga toxin producing strain, So the use of antibiotics that actually affect the cell wall or break down the cell wall further predisposes to release of more toxin into the system, thereby predisposing them to more severe diseases. So the use of antibiotics is restricted in patients that have typical HUS, not in patients that have atypical. So in patients that have atypical, but even in atypical, you have to find out actually, is it because of an autoimmune disease? Is it because of a malignancy, pregnancy related, or all this? But in patients that you are able to identify that strep or Shigella are the predisposing factors in this patient for their atypical HUS, you can go ahead and give antibiotics.
Yeah, thank you, Dr. Mustafa,
Thank you, sir.
for that.
You're welcome.
Sure. Any other questions, clarification? In the chat box, everyone is including. So well done.
Thank you.
Any other contributions? Okay, the time has fast spent, so I'll hand over to our teacher, Dr. Christopher. Dr. Christopher, ma. Oh, Shitusa.
Yes, Dr. Asha, anything? Sorry, I was not paying attention like that. Yeah.
Close to her